Okay. So is the patient MMI or PNS? This continues to be an interesting challenge, and I get not infrequently questions from providers as to what to do with a particular patient. Are they MMI, maximally medically improved, and permanent and stationary? And of course, you recall that MMI is the medical concept that patients really as good as they're going to get for the next for 12 months. This is a work comp. And the administrative or the carrier's claim management term, permanent and stationary. So I want to talk about one, and then Amanda's going to comment about this particular patient. And there's so many patients where the decision about MMI, PNS, there are different situations. It's we can kind of group them together in some clusters, but it's not always really a straightforward decision. So it takes some consideration. So here's a 56-year-old male, July 10th of 2001, was getting a bag out of the trash container. A 30-pound lid closed on his head. He initially went to the ER, where a CT of the head and neck were normal. On the 12th, came to a DOD clinic. He had what was described as a 10 out of 10 headache and some neck pain. And then there was numbness in all four extremities. Physical therapy was ordered. And then referred to the neurologist for an EMG that was done and found to be normal. The carrier, as they often do, reported the claim on delay. And just to refresh everyone's memory on this, carriers, if they're uncertain, have questions about causation. In other words, is something really job related or not? Then can put a claim on delay for up to 90 days. And during that time, as long as we're treating according to the medical treatment utilization schedule, we'll pay for care up to an aggregate of $10,000. So they'll authorize going ahead with physical therapy or whatever it is we want to do, as long as it meets the criteria for MTUS. And then they'll make a decision. And during that time, a patient who's not working while the claim's on delay is not paid, although that'll be made up later if they decide to accept the claim. So in any event, this claim was put on delay. Headache persisted, tingling in the right wrist and fingers. And then MRI of the head brain was done and found to be normal. And in mid-December, referred to neurologist Gerald Wall, reported, quote, a relatively trivial injury, close quote, prescribed Voltaren and no follow-up. And I will say, Gerald Wall is a guy, if the patient's complaining about anything, tends to hang on to patients, and care can be, or observation for a long period of time. So if he said relatively trivial injury and no follow-up, he really thought that there was not much of a problem here. So by mid-January, physical therapy wasn't helping. There was no fault of the neurologist. In mid-February, continues to experience headaches, dizziness, numbness of his tongue and feet when he walked. Repeat C-spine because of pain. Then X-ray was negative. And then a report came back from Vibrant Care PT in Santa Cruz, where therapy was going on, indicated no improvement. We didn't know how many visits, at least I couldn't tell from the record how many total visits, but apparently the therapist said no improvement with the care rendered. So by early to mid-March, he was continuing to have headaches, dizziness, I presume neck pain, now diminished memory. And there were a total of 13 visits to DOD and 8 months since the date of injury. So at this point, he seemed to be really unchanging, not better, not worse, just kind of in there. So Amanda, maybe you can make comments about, we talked about this fellow. What was your take on him and the situation?
Yeah, so I came upon this case, I guess February, somewhere around there, February, March. And I looked at it and thought, like, well, this seems kind of ridiculous. I don't understand what's going on here. He had seen multiple different providers initially, just kind of bounced around. It looked like maybe he was a weekender based on the providers that he saw. And so I think that was maybe part of the problem was, he was just seeing a bunch of random people that weren't seeing that nothing was actually changing, and that the symptoms were really kind of strange for what actually happened. They didn't seem to line up very specifically. And so when I saw him, and I will say part of, I think the problem that I had, because of course, then I came along and was the bad guy. He was a Spanish speaker. So I couldn't relay directly with him. We had to use a translator, or one of our staff, actually. We never had an actual translator on site when he came in. It was just one of our MA staff. And I was trying to explain to him that his symptoms were not, I didn't want to invalidate his symptoms, but they didn't line up with the actual injury. So I was concerned perhaps something else was going on that he needed to see his primary care for. I also noticed that he had high blood pressure consistently. And the report that we got back, he was, the first time I saw him, I told him to go back to work, and he fought me tooth and nail the whole way. But I told him he needed to start going back to work and start getting his life back to normalcy. Hopefully he would feel better, which is common. And, he was really pissed. He came back and he actually wanted to see a different provider altogether, but they put him with me anyways. And, he kept insisting and that other provider wasn't available at the time. And it kind of almost felt, to be honest, like it was maybe, I couldn't tell if it was manipulative or if he just really, truly in his gut was set that all these symptoms were related to this specific injury. But, either way, the provider he had been with before was a little bit newer, and she'd been trying to convince him for a while to go back, and he just refused. So I just had to say, you have to do this. This is no longer, it's no longer going to be a case where you just stay off. If you choose to stay off of that or quit that job, that's up to you. But just trying to convince him that the symptoms weren't related was really challenging, because as I would talk, he would just come back to me with a list of all of his symptoms. And one of the things he came with at his last visit was his physical therapy report, saying that his blood pressure had gotten really high when he was there, and therefore they had to stop therapy. And that somehow proved to him something. But he didn't, as far as I could tell, he didn't have any insurance. I'm pretty sure he did not have any insurance outside, and had not been to a doctor in a very long time. So I was trying to tell him, I think you might have these headaches still because your blood pressure is too high, and you really need to get this under control. And we can see you for that separately, just not under work comp. So yeah, when he was in PT, the blood pressure had gotten upwards of 180 over 120, I think. And so just trying to, impress upon him that that's dangerous, and you need that treated, and it's not related, was particularly challenging with language barrier. So by his last visit, it was kind of the first incident where I've really had to just say, I'm sorry, but I read the neurologist notes, and all of his scans were completely normal. The neurologist had said, pretty minor injury with still reported, symptoms. I would suggest he do PT and then go back to full duties in a month as motivated. And I felt like, okay, that was a month prior to when I saw him. So I was trying to do gradual build back to regular duties, but I saw that wasn't going to happen. And so I just had to close the case. And I knew he was pissed, and that was, that's kind of hard, because, you're going to get a lot of backlash from that. But actually recently I had our front desk call him, because I don't speak Spanish. And so I had them call him to follow up and make sure that he did see a provider for his blood pressure. And he had not yet. So they urged to him that he really needed to do that, because that was dangerously high and blah, blah, blah. That could be the cause of his headaches. I have no idea why he was having all this numbness down to his feet and his tongue and all this other stuff. But his exams were totally normal in office. There was no slurred speech. There was no disorientation. So yeah, it was a little bit of a bummer, but he just really would, he actually would say, I don't want to go back to work and die. I don't want to go back and have a stroke. And I was like, well, a stroke is a real risk, but because of your blood pressure, which is not related, which he just did not believe. And I told him, it's totally up to you if you want to quit this job, but it's time for this case to close.
Yes, that's a great summary of a very challenging problem. And it brings up kind of two issues. One is, how do you deal with this kind of, just from a medical standpoint, regardless of whether or not you're trying to make an MMI decision, what do you do with a patient where you get to this point where you've kind of run out of things to do, and it's obvious from a medical standpoint that there's not something to treat, and in fact, the injury itself was relatively trivial. And then how do you separate that from what seemed to be bona fide non-job related problems, although his anxiety and frustration was probably making his blood pressure go up from time to time, but that was not the underlying problem. How do you deal with that situation? And then the other is, when do you call somebody like that MMI? And it can be a real challenge just from the standpoint of work comp, because we need work comp, we all know, is not the same as group health. Those are two intersecting but not concentric circles. So they overlap, but there are parts that are separate. So in the California Code of Regulations, permanent stationary status is the point when the employee has reached maximal medical improvement, meaning his or her condition is well stabilized and unlikely to change substantially in the next year, excuse me, with or without medical treatment. So that's what work comp directs us to consider. And you'll remember this graph. We've seen it over the last couple of years. And most patients are the A line. They'll have whatever problem, they'll peak at some point, and then their symptoms will remit, and they'll come back to the baseline of being asymptomatic and no physical findings. They're recovered. The B line that you see are those patients like this fellow who peak at some point, but then kind of wax and wane. It's sort of a sine curve in a sense. They have some days, weeks, or months that are better and some that are worse, but the symptoms never fully remit, and they never go kind of above a certain point. And we need to recognize that whatever the insurance situation is, when patients are getting to this point, because this question will arise in group health as well as work comp. And then we've talked about the C, D, and E lines, and we'll talk about those more another time. So what we're trying to do is recognize, when are we on the B line and no longer on the A line with an expectation of returning to pre-existing status, full recovery. And that can be a very tricky thing. It has to do with assessing symptoms. Are the patient's symptoms stable or fluctuating? And if they're fluctuating, are they fluctuating within a certain range? Physical findings, similarly, or what you're observing, whatever it is you're measuring, are they stable? Or are they fluctuating some, but they're fluctuating in a particular range? And there's no test that's going to tell us this. This is really clinical intuition, trying to make that judgment. So we're trying to decide this. And then what are we considering? In addition to the symptoms and physical findings, what labs available, what neurodiagnostic testing, radiology, imaging, therapy, physical therapy, or other appropriate specialists, have they been consulted? And you gather all that information, and you're asking yourself, is the patient now kind of on this sine curve, sine wave, and has everything reasonably reasonable been done? You know, you could go on for years doing psychological testing and excuse me, other kinds of things, but what are the reasonable things to be done, and have they been done? And that's part of the decision making. And then a big piece of this, from my standpoint, and I think it's all of ours to some degree, is just the intuition about a claim. So you stand back and just kind of reflect on the case. What's reasonable here? What would a reasonable person say about this situation? Does it really look like, and you know, we get these gut feelings when we talk to patients. We come to these conclusions, as Amanda did, that there just really isn't anything more really to be done, reasonably to be done. And then we need to be willing to close the active case, you know, and not necessarily follow the patient. But then there's some steps to this. So how do you manage this kind of thing? A piece of it is making that decision. And then a piece of it is the challenge of discussing it with the patient. Some of the patients we see are, you know, relatively bright or very bright. Some cases maybe brighter than we are. And so you can have the conversation about this and they'll understand what you're talking about. Other patients are challenged in understanding, and they'll come at this with kind of a preconception. In other words, like this fellow, you know, my blood pressure is up. I wasn't up before. Of course, he didn't know. It wasn't up before. It's obviously got to be due to this injury. And not only is it due to the injury, it's corroborating the fact that I had a serious injury. So they come at it with misinformation, and I'm not being pejorative here and not being critical of the patient, but they come at it with different funds of knowledge. So we need that needs to come into our consideration as we deal with this. And so the approach I take to patients like this is to explain to them what's going on, what have we done to date, which is bullet point 3 there, reviewing the case to date, just indicating that we've really kind of run out of things to do. And I will say to patients, you know, medicine's an imperfect science. Most of the time we can solve problems, we can make people well, and they'll be fine. But that isn't always the case. There's a certain percentage where we just can't get the patient back to normal. And so I explain that to him. I acknowledge their symptoms. You know, I have found over the years, it's a very difficult thing to try and talk patients out of what their symptoms are. And if he's got numbness in the tongue and memory loss after having you know, a head injury and other things, you're just not going to talk him out of that, unfortunately. And so I'm just simply acknowledging, I'm just saying, you've got these symptoms, I get it, but we're just not going to be able to resolve this for you, unfortunately. In a few days or a few weeks or a few months, or maybe never, you know, this may change, but for the time being, it's just not going to change, and it's not likely to change anytime in the near future. There's no evidence that anything serious is going on, other than maybe your blood pressure that needs to be treated and can be treated separately. But just acknowledge what's going on and kind of review the situation with them. And some number of these patients will have the sense. In fact, I'll usually ask them if they have the feeling that they're just not likely to change. And some number will kind of fess up and, you know, they're not happy with it, but they recognize it. And then the approach I take with work is to say, you know, we're on a path now, we've got two choices here. I say, yeah, I realize your symptoms aren't going away. It makes it tough to work. I get that. Here's a choice you and I need to make together. One is to say that the pain's going to be there, and you've got to tell me if you can work through the pain, if you can do the job with the pain, because it is what it is for now, and your job is what it is for now. Or are you just simply unable to work through the pain? Is it more than you can manage? I let them tell me that. And then I say, okay, the way this is going to work is then I'm going to leave the restrictions in place. If you can't work with those, then you need to talk to your employer about that. They may be able to accommodate these restrictions or they may not. But if you can work through the pain, then let's go ahead and have you do that. And I may have some restrictions on them, or I may send them back to regular work. There are some situations where folks just can't, in fact, many where they just can't afford to lose the job for various reasons, financial and otherwise. And they'll admit, well, I don't want to take a chance on losing my job. I'm going to try it, and I'm going to send it back to regular work. I'm going to send it back. They're going to go back with a few restrictions and really try and make it work. And if it doesn't, then I say, okay, that's the situation. What we're going to do is notify the carrier, send in a report, indicate that these are the restrictions and that you feel you can't work with the restrictions. That's something you can talk to the carrier about and settle your claim on whatever basis. And then I just again explain that the way workers' comp is, this isn't like going to your family doctor for a chronic problem. Cases in work comp just don't stay active forever. And we just have to work with that situation. I explained to them, when the claim's settled, there can be provision for future medical care, but that's something you'll work out with the carrier. That's not something, I'm going to decide. I mean, I may recommend it, but there's the possibility of future medical care. And then I put down the fact that I've talked to the patient about these things. I make provision for the PR4. So I just mentioned most of this. And then plan for the PR4, and we can either complete it in a clinic, which I don't do very much anymore. The state has a form we can fill out. What I'm doing most of the time is sending them off to Rate Fast. If it's more complex, multiple complaints, then Tanya Kujak, we're sending the patient there. So I send them off, complete the PR4, and then that's the end of it. I don't see them again. I don't have them back to go over the results of the PR4. The only time I would schedule them to come back is if they've got something like diabetes that is part of the settlement, then they obviously need to be treated for that. But they've got low back pain. I don't have them back, and it's up to them to work out with a carrier whether they're going to get future medical care or not. Send off the PR4. One of the reasons for not having them back to discuss the PR4 is that's only one part of what the adjuster uses in a final claim settlement. They'll also consider the patient's age, what their job is, part of their history, if there's pre-existing problems. And if we tell the patient that the whole person impairment is 10%, and then the carrier comes back to them with 4% because of those other factors, then they're unhappy and they want to know what's going on. And that's an issue between them and the carrier. So I don't have them back to talk about the PR4. So I do that. And then that's the approach I take. Anybody take a different approach, have a different opinion about this? Any guidance, any wisdom of your own personal experience in trying to deal with this sort of situation?
Steve, I want to just throw in, I guess, my 2 cents after doing this for almost 30 years. Not as much experience as you have, but when I saw that report from Dr. Wall and then negative MRI or CT, whatever they had, where it said the specialist I sent them to says, no further treatment necessary, trivial injury, whatever. To me, that's like this golden window to close the active part of the case right then and there, and have that discussion like that day, and really try to move that patient out of the active work comp world and into either future medical care or care with their primary after that. Once you get a little beyond that, or you try, let's do physical therapy, in my experience, then you're in for the long run. I think it's just much easier right then and there to have that conversation with the patient while everything's fresh, everything's normal. The patient still has symptoms, so you have to have the conversation you discussed with them. But I really see that as like this really golden moment to close these cases.
I agree with that. And unfortunately, we don't get that statement very often, in my experience, from the specialist. But yeah, that is very helpful, which is why I put it in quotes, and especially from a guy like Wall to get it. It just that's really, really unusual. So, the timing on these, I agree with you, Scott. That may be a watershed moment, and you just you move on it there. It's just whatever you think is the best way to handle a patient. Once you get to that, you certainly don't want to drag it on much beyond that. And this is the thing about following a plan here. And we've talked about plans before. I think that we really ought to have a sense of where we're going with the patient, which is one of the reasons that, to the extent we can, trying to keep patients with one provider, or maybe two, but ideally one, it really facilitates having a plan for a patient. So when you get to the point with whatever information, and I agree, something like that from a specialist is potentially a place to say, okay, enough's enough. Then you have that conversation. And these are not easy discussions. I think Amanda handled this really well. And it's different patients are going to respond in different ways. And what we need to do is try and meet the patient where they are. What are they going to understand? And you don't want to get in a debate with a patient about anything, about symptoms or whatever. You want this to be a one-way discussion, except when you get to the point of saying, okay, let's decide about sending you back to work. But I agree, when you get pieces of information like that, that's a signal that it's probably time to close the case.
Would you also, in this instance, I really, did not want to have any restrictions on him, permanently. Is it, two questions, is it true that those restrictions would follow them like forever? So that way, if he's trying to get another job, he would have this restriction in place and it would be hindering to him. And then the second question is kind of, do you ever, I know we always want to include the patient in the decision, but would you ever do kind of like what I did, where I was like, I know that putting this permanent restriction on you would be damaging to, I'm pretty sure he's undocumented, doesn't have insurance, doesn't have anything. And I didn't want this stain on him for the future. So I kind of just decided, all right, I'll be the bad guy, but really you have no idea in the future, this could actually follow you in a negative way. And I'm preventing you from that. Is that something you would ever do?
That's a very insightful question, Amanda. And that comes up, the consideration is periodically there. Here's something, the way I see it. Once there's a settlement on a claim with permanent impairment and some degree of disability, yes, it is there. It's part of the patient's record. However, what happens as a practical matter is, with the next job, unless the patient tells that to the employer, I've got permanent disability from a prior injury. I've seen a number of cases over the years where that just doesn't happen. They just don't share with them. That's one thing we want to try and do, incidentally, in the first evaluation. That's the reason we're always asking, have you ever had something like this occur before? And try and delve into it a little bit. Now, what happens is, so as a practical matter, it's there, but subsequent employers most of the time don't find out about it. If they have, however, another injury along the way, and there's some question and the carrier wants to get copies of old records, carriers from the different insurance carriers can access a database where the resolution of claims exists. So the patient works for an employer now who's carrier state fund, and previously they had an injury where it was Liberty Mutual. State fund can get access to those prior records. They've got to have a good reason for doing it. Claims got to be accepted, but they can get that. And then what I'm interested in, once I discover that they've got a prior case, or the carrier does, is I want to try and get a hold of a copy of the PR4. that was done, permanent impairment evaluation. But to specifically answer your question, yes, it's on their record permanently. No, in the vast majority of cases, it has no impact because the patient never shares that information. Very good question. Any other questions? Anybody got any suggestions about how they handle this or frustrations they've had or?
Yeah, Steve, I think this just brings up this very common and situation with providers, not only at DoD, just everywhere, of our desire to solve things and the bad feeling we get when things aren't, our patients don't get better, and we feel like we're closing a case and the patient's not better, and it really nags at, I think, it nags at me, it nags at all providers that how do I how do I do this to this poor person, and I think sometimes unfortunately you have to make a tough decision based on objective findings, CTs, MRIs, specialist reports, and it can be very, very hard. And a lot of times your gut feeling is tell you to just keep trying something else or try this or try that. And I think it's something we have to consciously resist and really step back. It's easier on this case, I think, to see what to do when you're reading about it. If I was in the room like Amanda was, it would be very hard to make these kind of objective decisions. Yes,
that's really a great point, Scott. And in fact, it's harder when the patient's angry.
Yes.
I agree with you. I agree with you that, we're trained and our natures are to heal people, and it is unsettling to have patients that we can't resolve their symptoms. Sometimes we feel inadequate. Sometimes we get frustrated with the patient, whatever the thing is. But we need to be recognizing, and this applies to group health as well as work comp, is when we have that discussion with the patient and say, we just can't make you any better. And I think one of the other reasons to not just continue treating is we want to align the patient's expectations with ours. I think when we continue trying to do things, we're telling the patient there's still some hope that you're going to change. And at some point, we have to be sure that the patient understands it, has a real understanding of what their problem is, and the fact that they're just not likely to get any better. I think we do them, in fact, a disservice oftentimes, continuing to try and do things when we recognize, and the patient may, or may not, recognize that they're just not going to change in the foreseeable future. Medicine's an imperfect science, and our bodies are imperfect things. And not all things can be solved. And the other thing is that I think Amanda was correctly sensing was that there are other issues that can go on that we don't know about that's causing the patient to be this way. Sometimes they don't like their supervisor. They don't like something about work. They've got family problems going on. They've got, whatever. They're just things we don't know. And we're not psychologists, psychiatrists. We can't delve into their psyches and figure these things out. There's nothing there that we can work with. So in any event, I think what we need to do is be honest with the patient. And when we recognize both medically and intuitively that they're as good as they're going to get, we've just kind of run out of things to do. It's really a disservice to them, I think, to do anything other than to be honest like that, and then help them plan for the future. And if they're not going to be able to go back and do their regular job, then we need to, give them some advice. But we also need to be giving advice to the employer and insurance carrier about how, what management, if any, needs to be done. And so we work within the work comp guidelines. We better wrap it up. It's 4 minutes after. We were going to have another section on our pre-op exams, but we'll save that for next time. And I think we're doing something in Epic that'll be maybe ready by then anyway. So
can I ask a super fast question?
Absolutely, Monica.
once they are discharged from our care from work comp, can they then go back to their primary care and receive treatment for these ailments?
That's between them and the carrier.
Okay,
And of course, one consideration is there are precious few PTPs that are willing or want to or can treat work comp. So, but yes, that's certainly an option, and some people will, end up doing that, and that's always great. The other problem, of course, is so many of the folks we see, especially farm workers, blue collar workers, often just don't have a family doctor anyway. But
Right.
yes, that's an option. But again, that would be between the carrier and the patient.
and when you say the carrier, does that mean like the adjuster?
Yes, the carrier is the company, and then the adjuster is the person at that work comp company that is managing the claim. So, right, when I talk about carrier, I'm talking about the adjuster at the work comp.
So that's who they would take it up with, is with their adjuster. That's the
That's right.
individual.
They're
Okay,
gonna,
thank you.
they're gonna settle the claim, and they'll settle it in one of two ways. I'll just say this really quickly and then we can go. They're gonna settle it in one of two ways. One's called CNR, compromise and release. That's where they get a bigger chunk of money, but there's no future care. The carrier signs off, patients on their own. And the other is a stipulated decision. Carrier will stipulate for something, which is usually future medical care, and they'll pay them some money, but less money. So I tell patients, my advice usually, because I have a little piece, I'm not an attorney, I don't try and be an attorney, but I tell them, I think you've got a problem that is going to need care in the future. However you settle the case, I recommend you consider getting future medical care. The carriers always want to try and do a CNR. The attorneys, even the patient's attorneys, want a CNR. It's a financial thing, but what's in the patient's best interest is, in cases like this, be sure you're getting future medical care. And then, then we may end up seeing him again, but it'll be on a somewhat different basis.
Yep, Monica, there's one quick last thing. The other option, if this patient had a private health insurance, I would sometimes tell them that, from your work comp injury, it looks like there's no objective there's no objective findings. It looks like your case, this is over and your case is closed. However, I would see your primary care provider for your hypertension, which may be related to the other symptoms you're having with the numbness and so forth, and have them look into it.
Right.
So
I was thinking more of like musculoskeletal pain that's going to continue, and they may need, anti-inflammatories and muscle relaxers down the road. Who's
Right.
going to prescribe that for them?
Right.
yes, so you could do it, one of two ways. And I often, if they have insurance, it makes it easy. They have private insurance, it makes it easier, right? Because they can go to their private physician, and it all depends on what you tell your private physician you're coming in for. And
Yeah.
I'd say you're going in for hypertension and numbness in your legs. So anyway, that's just another thought.
Thank
Yeah.
you.
The question is if that group health insurance is going to cover what may come to them as a work comp claim, and they'll turn it down. The two groups that I see this where patients can end up getting care on a non-industrial basis are Medicare and Medi-Cal. But that, I'm not sure that's fair, but that becomes another subject. Well, we better wrap it up. Thank you very much for your attention. Thank you for great discussion. Appreciate that. And this will be, if you can't wait to revisit this and go on YouTube and listen to this 2 or 3 more times, it'll be out there.
Thanks, Steve. This is like my favorite morning of the month. Thank you.
Good. Thank you.
Thanks, Dr. Schumann.
Thanks a lot.
Thank you.
Talk to you later.